Everybody ready?
Ready.
Okay. All righty, so thank you for the invitation, Julie. Thank you, Michael Grandner, for making sure that I accepted the invitation. And thank you to the Sleep Advocacy Forum. So we'll start with the premise that sleep health matters. I think we're preaching to the converted here, but sometimes I think we lose perspective a little bit in that how much poor sleep is related to poor psychiatric and medical health. And here's just a brief schematic to make the point that poor sleep, generally defined, is related to a host of medical and psychiatric disorders, from heart disease to obesity to diabetes to PTSD to depression. And depression is where this linkage, in my mind, is perhaps the strongest. And I think that there's clear and convincing data now that it is very much a reciprocal relationship. But I won't be surprised down the line to find out that many of these health sleep links are more reciprocal than unidirectional. So sleep health matters. What's the problem? The problem is sleep health is generally not a focus for primary care. And I very much appreciate the last presentation. I've been there too, wondering about how can we bring this to primary care and what's the problem? Shouldn't this be a major focus? So why isn't it? First is patients may not view sleep disorders as consequential. Patients often don't report their sleep concerns. I call this the don't ask, don't tell policy. Patients often view their sleep concerns as secondary. And this one is perhaps our biggest stumbling block because we have promoted this concept even within the sleep community for generations. So this is a big one of many problems. Clinicians often don't have training in sleep disorders. Clinicians don't have an efficient way to assess for sleep disorders that fits with the workflow. In the last presentation, I think it was by Dr. I can't pronounce your last name, it was by Dennis, really drilled down on making something useful for and fitting with the workflow of primary care. And I really do appreciate that approach. But as you'll see, we have a different one. Clinicians may not view assessment or treatment of sleep disorders as essential for care. Clinicians often have the view that sleep concerns are secondary. So this is true of patients. It's also true of clinicians. And finally, even if all of this wasn't a problem, clinicians may not have clear pathways for treatment or for referral. So what's a potential solution? A brief, comprehensive sleep disorder screener. Okay. How brief is brief? 2 is pretty brief. +7, 9 is pretty brief. So I think that was a very good start. Again, I'll emphasize that ours was a bit different. But back in the day, in 2016, Dr. Karen Klingman decided to have a systematic look at what was available at the time. And what she found was published in this study. And it's basically as follows. But the problem we identified in that effort was that none of the existing screeners are or were brief and are or were comprehensive. So this is a table from that study. And what you can see is over here is a list of the questionnaires that purport to be global screeners. And what you'll see is some are short, like 11 questions. Some are not short, like 175 questions. But what all of them have in common is none of them have more than 6 sleep disorders, and most don't do that. So there's a real question about how comprehensive these things are. So roundabout that, so arguably, what we want is something, as I said, brief and comprehensive. And when I say comprehensive, the goal is to concurrently assess all 13 sleep disorders. Now, we can argue about, are there 11 sleep disorders or are there 15? Is this representation not fair because you collapsed RLS with PLMs? Is it not fair because you have 2 levels of not otherwise specified disorders for pathological sleepiness? Shouldn't it be 11? Maybe. Should it be 15? Maybe. Somewhere around 13 disorders is what we want to comprehensively assess. So a potential solution was not really made for this in the first place. The potential solution came from our need to have a rapid screener for research purposes. What we wanted to stop doing was having 1 or 2 hour phone calls with each subject that volunteered for a study to comprehensively assess whether they met the inclusion and not the exclusion criteria for our study. So originally, the SDSCL, the Sleep Disorders Checklist-25, was made for research to be a rapid screener, and it really worked well. And that's, for me, was the end of it. But thanks to Karen Klingman and Carla Youngquist, they kept saying, let me show this to a few clinicians. Let's see what they think of this. And more, we found that people wanted copies, that this is a really good device. It's very quick, very comprehensive. It was tweaked over the years. And eventually it came to look like this. This is a paper version. And what you see at the top is some header information about age, sex, height, weight, work shift, what the total sleep time is, what the time in bed is. Here are the 25 symptom questions, and then they're scaled from 0 to 4 on a frequency/intensity basis, from 0, never, to 4, which is greater than 5 times a week that I have this symptom. Okay, so this is what the questionnaire looks like. And I actually now see the bottom of my slide. It takes 3 to 5 minutes to complete. Frankly, it could be done in 1 or 2 minutes. Modal is 3. It taps, as we said before, all 13 sleep disorders. Interpretation is easy peasy. There it is. The last 2 columns represent greater than 3 days a week symptomatic for each of these items. And so if you wish to follow up, to assess, to diagnose, or to refer, these are the areas you're going to focus on. There's also a digital format. This is one version of 2 versions. On the digital platform right now, you just toggle this little switch, and it can be either card format or whole page format, like the paper. We're also developing whole page card formats, which is 1 question per page. Very good for phone apps, I might add. And patients and subjects can choose how they want to complete it by toggling. Survey can be taken anytime, anywhere, where there's a laptop or a computer. And interpretation is easier still because there's a report. And what the report does is says what people are symptomatic of. In this case, it's insomnia, OSA, RLS, and parasomnias. That's also graphically represented and numerically represented in the table. It is a highly interpretable report for what patients are symptomatic for that survey that took them 3 to 5 minutes to complete. So as I didn't say, the red line in the graphic is what we're looking for people to be above, which are symptoms that may warrant further follow-up. Once they've completed the survey, there's a pop-up, looks like this, and it tells people how to access informational resources through the NSF or through the American Academy. It tells them how to find a sleep disorder center, and if they're looking for providers in their city and their state, it links them to provider directories. This also is sent, if they choose to have it sent to them, by an email. So this is what the email looks like. So what are the next steps? We are doing, pushing forward with something we call the Sleep Health Screener Project. The goal is to collaborate with industry sponsors to create a public-facing, open access website and a phone app, where the screener can be taken online anytime, the completed questionnaire can be saved, the report can be downloaded, the results are emailable, and access to provider information is given. So that's where we're at. Thank you for your interest, and hopefully there's time for questions.
Thank you so much. This is just so fantastic to see all the work that's been done in this area. Have you guys been able to track at all the follow-up of people, similar to what Dr. Huang was talking about, whether people are actually following up with sleep appointments or?
Right. There are a couple of critical questions there. Let me stop sharing so you can stop seeing various screens pop up. We have done several studies in hundreds, if not thousands at this point. Some studies are more interested in symptom profiles across a given disorder like Parkinson's or Alzheimer's. In terms of, does it work? That's the critical question. If we put this out in the internet, will people hit on it? Yes, we're fairly certain of that. If you just Google, why can't I? The most universal reply is sleep. And if the first link is us, they'll have the opportunity to screen. Now, I happen to think when patients seek information, they're more likely to act, as opposed to in the primary care office, they're handed, let's say, a tablet, here, take this, they may be less likely to act. So when people are in help-seeking mode and they're going online to look for what the hell is wrong with my sleep, my hope is they will take hold of those recommendations, those referrals that we're giving. But that's an empirical question. But I also think it is a question that we can address once we have it up and live. And, you know, even if it's not perfect, it's a damn sight better than what we have now. What we have now is don't ask, don't tell. If you do tell, people drill down on specific sleep disorders and ignore the rest. We don't want that to happen anymore. We want there to be an opportunity for all of the sleep symptoms to be assessed concurrently so that we can get the big picture. Maybe it's not just idiopathic sleepiness. Maybe the person also has nightmares and bruxism, which is, by the way, likely. So, or possible anyway. So we're hopeful. We've done an awful lot of work to get this to where it is. Where it needs to go is industry support to put a beautiful version up for free for everybody, and then to hope that we're giving back the information in ways that they'll make good use of.